This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Tisha Manteep with the Neurology podcast. Have you ever been in clinic with a patient with migraine and wish there was a more systematic way to select an acute treatment regimen? Well, there's a new paper published in the British Medical Journal called Comparative Effects of Drug Interventions for the Acute Management of Migraine Episodes in Adults. Systematic review and network meta-analysis, which seeks to address just that question. And with me to discuss are two of the co-authors of the paper, Professor Andrea Cipriani, who's a professor of psychiatry at the University of Oxford and director of the Oxford Precision Psychiatry Lab, and Professor Masoud Ashina, who's a director of the Human Migraine Research Unit at the Headache Center affiliated with Copenhagen University. Well, thank you both for being on the Neurology podcast. How are you?
Good. Thanks, Tisha.
Thank you.
Why did you set out to do the paper? I mean, there's been other systematic reviews on acute therapies for migraine. Why did you feel like we needed to look at the data again? And how did you start this collaboration?
It was Masoud and his team's idea, trying to do something in an area where there are many available treatments, but the great majority of the data is about a comparison between the active intervention and placebo. So the network meta-analysis technique that we used previously in depression, psychosis, and other fields of medicine, of course, is very useful in this kind of situation because you can compare treatments that have not been compared directly in a trial.
The story started in Copenhagen. My junior associates, encouraged me to contact Andrea because they told me that he's one of the best in this field. His paper in Lancet was a very important paper, network meta-analysis comparing the antidepressants. And when we read this paper and discussed this paper, we decided that this topic is not something that we can do alone because it's quite complex. And you really need a teamwork. You need experts to do this kind of a complex network meta-analysis. The collaboration initiated. We found out that indeed it is a quite complex. And it took us how many years, Andrea?
3 years.
So you can imagine that many people think that, it's very easy way to do it, the network meta-analysis. But we found out that it's extremely complex and it's time demanding and it needs a manpower. We had a lot of people. You can see the number of people involved in this paper. All of them participated one way around. And with Andrea's expertise, we achieved this nice result. And as Andrea also mentioned, that rationale behind that was that when we start comparing all these medications that we use in migraine field, to treat attacks, abortive medications, the huge number of these medications, the question is always, is it any difference between these medications? Which one is better compared to another one? The gold standard, Tisha, is head-to-head trials. But unfortunately, not many, let's say, companies, the pharma are interested in this kind of design and this kind of studies. And that's why this network meta-analysis can help us to understand the differences between these medications, in particular in the light of the new, medications coming in our field. And the question is that, how we can rank them, compared to each other. And the idea was that by doing this kind of network meta-analysis, we can guide in the future clinicians which drug to select as the first choice, and then the second and the third, et cetera, et cetera.
There's not many head-to-head studies for acute migraine therapies, and we should just start off with saying that migraine is a huge problem. 1 billion people around the world with migraine, and almost in some studies showing almost all patients have at least one unmet need for acute therapy. So we know that we need to find better ways of selecting acute therapies for our patients. What makes your work different than other studies that have sorted this out? I know that you've collaborated with some patients, which is really cool. So tell me a little bit more about that.
Yeah, there are a few things that we did differently, because you're absolutely right. There are already existing network meta-analysis or previous network meta-analysis, but they were less comprehensive. So they selected only a small number of comparisons, or they were only about published studies. But actually, it's important to collect the unpublished data. And the third limitation, they only focused on a couple of outcomes, while we want to be more comprehensive in the clinical situation we analyzed. In terms of USPs of the project, one thing that Masoud and I are very proud is the involvement of representative of organizations of people with lived experience of migraine from the beginning, a real co-production, as we say in the UK. And they developed with us the protocol. They selected the outcomes that were relevant for the patients. And finally, they also interpreted the data with clinicians in a blind fashion. I always laugh when I remember with Masoud this episode, because I did the analysis with Eduard, a collaborator of mine in Oxford, and we went to Copenhagen and we entered this room full of experts, clinicians, academics, and patient representatives. We presented the data in a blind fashion. So all the data were A, B, C, D. No way that they could understand which was the drug we were talking about. We discussed the data. They agreed about the final interpretation. And at the end, we revealed the name of the drugs.
So, Masoud, why don't you tell us a little bit about the outcome measures and how those were selected? And it sounds like they were patient-friendly.
The most important outcome measure for patients is that when I take my tablet, I am pain-free. The International Headache Society guidelines for clinical trials, that 2 hours pain freedom is selected as the good outcome measure. Patient wants to be pain-free. And we realize that it is an oral formulation. We're talking about only one drug, not the combination medications here. And in this case, 2 hours pain freedom was considered as a meaningful. In addition, also sustained pain freedom, because the patients, they don't want to, have any headache, not coming back, no recurrence during the, 24 hours, sustained pain freedom. And another point, Tisha, is that, as you know from the clinical practice, that people also with migraine, they ask about the tolerability of this medication, the side effects, adverse events. So that's why they've also been included in our outcome measures. But we also have some other outcome measures, as Andrea mentioned, that we considered also relevant. So we selected based on what we clinicians and also the patients they think the most important are.
And so how many patients overall were included in this analysis?
About 90,000 people across 17 drugs.
What was the quality of evidence when looking at some of these studies? Because we're comparing new drugs with old drugs, right? And older studies.
Yeah, but the beauty of the plots that we have, the Truthian plots, actually provide this information you are asking now, the level of evidence. Andrea, can you tell us about that?
Yeah, this is a standard thing that we do in all systematic review and meta-analysis, because, as you say, it's crucial to assess the so-called certainty of evidence, how reliable, how trustworthy are these results. And this is something we do per outcome, because the data may differ from one outcome to the other. And the quality ranged a lot, as it is for many other fields in medicine. The quality of the studies is materially improving over years. So the old studies were, of course, of, let's say, less robust methodology quality. There's always the big question whether this is related to a true difference in methodology or is more about the reporting, because the papers a few years ago, 10, 20 years ago, there were no guidelines about how to report the information about key features like allocation concealment or the selection bias that they may have between protocols and publication, because the protocols were not available. So it's something that we found which is not different from other fields of medicine. So I'm pretty confident that the quality is not ideal, but it is the best that we have, and it is good enough to make informed clinical decisions. The other thing we did in terms of, let's say, quality is to analyze one important feature when we do network meta-analysis, and we can come back to explain the methodology in a second. But we have these nodes, these big circles, which represent the number of people that were randomized to that specific intervention. And one of the key comparators, as I said before, was placebo. And one question that we always address in a network meta-analysis spanning from the 1970s to 2020 is how is the response to placebo changing over time? Because if the response changes over time, we don't have a reliable comparator. Of course, we did, and everything was fine. It's reported also in the paper. There was a change around the late 90s, but we did a sensitivity analysis and no material difference.
So that's interesting that the placebo has been generally stable, given newer drugs and high expectations for things like GPANs.
No, we don't see that. It's pretty stable.
That's very interesting.
Yes, we are looking at average effect. So even if the average effect of placebo is sort of stable, within each year we have a lot of variability, which mirrors what happens in clinical trials, of course.
Masoud, do you have any other comments from a clinical trialist perspective?
The outcomes we included here, those outcomes you see in the clinical trials. There is nothing, let's say, special about that. There was only selection of the most important based on what the patients provided us, their opinion about that. And each Vitruvian plot represents actually a placebo comparison, the proportion of people who reported pain freedom. This is important information. What is really new and I found fascinating is that when we have an active comparator, in this case was a sumatriptan, based on the colors, we can see the level of evidence. And I think that this is a very important for the clinical decisions, because some people might say, well, I'm interested in efficacy and I don't care about tolerability. Another one may say, well, for me, it's just a little pain relief, but good tolerability, so I can work, I can do that. So it will be up to the physicians to decide. We are not the judges here, but we provide this information. But we clearly have also here the 4 triptans, what we found that quite, efficacious in terms of pain freedom, and sustained pain freedom. Overall, there were clear winners here in terms of the efficacy, the size of effect.
So why don't we go into that? Your results reveal the efficacy, the side effect profiles, which I think are important. But let's first talk about those clear winners.
That was an interesting process because when Andrea presented the data in the blind fashion, we actually guessed correctly based on our clinical experience. I remember that when we mentioned elatriptan, and that was clear. We also have some previous analysis, but for this additional one, our findings showed that elatriptan, rizatriptan, sumatriptan, and zolmitriptan that had the most favorable overall profiles in terms of efficacy and tolerability. And those 4 triptans, they were more efficacious than the most recently marketed drugs, that we have rimegepant, ubrogepant, and lasmiditan.
So we got to talk about ibuprofen. So ibuprofen is in there, right?
Yeah, ibuprofen is a good painkiller, of course. The best performance of ibuprofen was in sustained pain freedom until 24 hours, and it was with elatriptan, one of the 2 top ranked treatments.
But the data is based on a very small study and the quality of the study. So that's why we are very cautious with this interpretation regarding a 24 hours pain freedom in regard to ibuprofen. And also, honestly, this is not something like I would also claim that it is true if I think about my clinical practice. It's not something that we see, yes, it is a really good one in terms of 24 hours pain freedom. No.
We'll talk about the limitations of the paper, but we don't see a lot of people that are taking ibuprofen in our clinic. So the heterogeneity of the patients also something to consider.
But Tisha, we have to be careful, when we say the people we see in our clinics. In our clinics, we see difficult to treat, people with a difficult to treat migraine, both in terms of acute treatment, but also for the prevention. So if we go to the population-based study, the situation is different. The people suffering from migraine, the first thing they do, they go to the pharmacy and get a painkiller. I know some of the most popular in US, as far as I know, are combination therapies, but it could be also simple analgesics. They go and get aspirin, they go get ibuprofen, etc. And then when they reach you, usually they haven't tried triptans, or if they tried triptan or tried only one triptan, and failure with one triptan is considered that maybe they don't have a migraine. And that's why they end up in your clinic for the diagnosis and for the treatment.
So why don't we talk about how the triptans compare to GPANs and then to lasmiditan?
Yeah, if you look at the plots, that we presented, that there was a clear difference between the triptans and the newly approved drugs. Even if you take their relative to placebo effect, you can see that it is similar to what you usually see when you take the simple analgesics. That said, doesn't mean that the people are not responding to simple analgesics. They will not respond to the GPANs, for instance, if we compare with the GPANs or lasmiditan. This is not true. They might respond for another one. This kind of comparison shows that they are not as good as the triptans. And for the future, let's say, ranking or guidelines, whatever we're talking, consensus papers, the problem is that we don't have a clear consensus, which specific agents from the drug classes should be selected initially. And in this context, I would say that the triptans are very important. Another problem, Tisha, is that we have been using triptans the last 30 years. But the problem is that if you look at the number of people treated with the triptans in US and in Europe, if we take these, two continents, we can see that there is extremely low number of people ever tried triptan, even the one triptan. So there is a huge unmet need there that the people are eligible for these treatments, but basically they don't receive the treatment. There could be different reasons. We cannot discuss about all the reasons, but probably underdiagnosed and still considered, as a strong medications, in my opinion, and that's why people hesitate and they just keep trying the different simple analgesics or combination analgesics, but not going to the triptans. And also this issue about the possible vasoconstriction also may play a role here. Even we know that over the last 30 years that we use triptans, we didn't see any increase in the cardiovascular events in any cases. And that's why we also need to bring attention that we have a quite large group of people. I mean, they deserve to get this medication because they're eligible for this medication and they don't. And in addition for that, in an essential list of the World Health Organization, we only have one triptan there, sumatriptan. So that's why we think that all these 4 triptans should be included. Of course, we recognize that there is a geographical differences in the countries. Access for the triptans could be also different. Maybe some of the triptans that we mentioned here as a winners are not accessible in these countries, only 2 of them or 1 of them. Well, could be the different medications as well, because we show the whole picture and it will be up to the physician and the patient to decide which one, they would prefer. But in terms of meta-analysis, head-to-head comparison that we conducted here, more or less, we try to do that. This is the best you can get evidence in terms of the differences between the medications.
You talked about adverse events. I want to make sure that we've also captured the differences in adverse event profiles between triptans and some of the newer drugs that are often perceived to be better tolerated. I think that's a really important point when treating patients, that they don't have side effects. That's also a very important outcome measure.
This is correct. Again, what you need to also to pay attention is the level of evidence. You really have to look at the colors, when you interpret that, even for the adverse events. They may report less adverse events, but the quality of data coming of reporting adverse events and the in general quality of data can be also discussed. This is something important for the future trials also to consider that. What do you think, Andrea?
I think that the beauty of the Vitruvian plot is that we can put some numbers. For instance, the question was about the comparison in terms of efficacy for an average patient. The probability of having pain-free at 2 hours with elytriptan is about double as the probability of having pain-free at 2 hours if you take lasmiditan, and even more compared to rimagepant and obrogepant. We are talking 37% versus 21 or 16, 17%. And you can do this with all the outcomes reported in the Vitruvian plot. So also about side effects, which were chosen by the patients. The side effect profile of the newer drugs, not ideal because they still cause a lot of side effects, but this has to be contextualized with the full picture, the efficacy data and the adverse events.
I guess we should also talk about some of the limitations to this investigation and how reliable the data is.
From a methodological point of view, of course, one of the key things of a network meta-analysis is how well the nodes are connected to each other. So how much direct evidence we have. We said at the beginning that the majority of studies are placebo-controlled. So the shape of the network tends to be like a star shape. So all the drugs connected to the placebo, but not too many head-to-head comparisons. And this is an important limitation because one thing that we always check in network meta-analysis is consistency, which is whether the direct evidence, A versus B, and the indirect evidence, A versus B via a common comparator C, if these two sources of evidence are showing the same results. If they show the same thing, direct and indirect, we say it is consistent. If not, it is inconsistent. And we have a way to calculate how many loops are inconsistent. And on average, almost all the outcomes had less than 10% of loops inconsistent, which is by chance. But one outcome, chest pain, was with 13% of the loops inconsistent. So as Masoud said, the quality or the certainty of the evidence is not ideal for this study. But of course, it is the best we have. The other thing is the unpublished data. We did our best. I mean, Masoud's team in Copenhagen, in collaboration with my team in Oxford, we did our best to dig all the unpublished information, but we cannot rule out that some of the data are hidden somewhere. And so the presentation of the evidence is not complete as we hoped for. The last point in terms of methodology is the heterogeneity. So in the studies, there's a bit of heterogeneity, which is not related to problems in the data. So we check the data and the data are correct. So probably it is reflecting the heterogeneity of the population that we included in the network meta-analysis. But again, discussing with the experts, the clinician, this also mirrors the complexity of the real world care. So I appreciate it is a statistical problem, but at the same time can increase the external validity, the generalizability of the findings of this paper.
So it seems like some of this was predictable in terms of triptan efficacy. I want to know what surprised you about the study findings.
You know, what really surprised me is that the newly approved drugs, their performance. What I hear from the clinical experience from other people, that they're pretty happy about these new medications, and I don't deny that. But if we look at these comparison studies, and also when they look at the quality of data for the actual outcomes from the clinical trials, they are not pretty impressive, I would say. And I had some feeling that probably the new medications, in particular the small molecules, you know, the GPANs, are probably better medications for the prevention rather than for the acute treatment. I also had some patients responding pretty well for these treatments, you know, when they failed to the triptans or they couldn't tolerate the triptans. So it is in the clinical practice, we do see that. But if we look at the overall comparison, we can see that they are not pretty impressive in comparison for the triptans. Among the triptans, I wouldn't say it surprised me that elytriptan was probably the best one, you know, among all the triptans, if we based on this analysis, because this is also something my clinical experience. But you can also have some other people, they will say maybe rizatriptan is more impressive, more efficacious compared to other triptans. that the people should have an access for the triptans. This is a very important message here, that the people with migraine, they need to get proper treatment. We also think that there is wide variation in performance, especially in terms of NSAIDs. And what we saw here, that diclofenac, potassium, in terms of efficacy and tolerability, it was close to what we saw in the sumatriptan. But there was some issues, as far as I remember, there was a large confidence intervals. And for the ibuprofen, I was surprised because of this 24 hours, sustained freedom. But it is driven by a single study with a very low placebo response. It's quite unusual, I would say. So that's why I don't consider that as important.
For me, the most interesting / surprising finding was that not all drugs within the same class are the same. I come from a different background, so I'm not an expert in migraine at all, but finding that some of the triptans are better. So it's not a class effect, but it's an individual molecule. This is very important for two reasons. One, of course, this will trigger further research and future research, trying to understand what is the real, or if any, the mechanism behind this specific effect or better effect. The second is because it paves the ground to precision medicine, which is exactly the approach we're trying to use in mental health with antidepressants, antipsychotics, and all other treatments. So if not all the treatments are created equal, even within the same drug class, that's a fantastic springboard to better understand what can work for each individual.
Great. And my last question is, what should neurologists listening to our program take away from this paper, and how can this knowledge advance clinical practice?
We can see that the simple analgesics, especially we have a paracetamol here, Tylenol, showed a very limited effect on pain freedom, but it was well tolerated, etc. I think that the people usually, when they try these medications, these simple analgesics, they need to talk to their physicians if they fail, in terms of the response to these medications. And this is a main problem that what I learned from this paper, I want my colleagues to understand, that the limited access to triptans and real substantial underutilization, it is, I can say, a missed opportunity to offer effective treatments to improve the quality of life of people who experience migraine. So this is very important message, I would say. So that's why, when we see these patients, they never tried triptans, they should try triptans. And now we have 4 triptans that, in my opinion, should be tried first. And then if they failed or they have side effects, not well tolerated or contraindications, they can go and try the new medications, which we know that are also efficacious if we compare them to placebo, but also with a side effect profile in terms of the contraindications. If you have a cardiovascular disease, can be also used in this case, that the argument, to start with the new medications. So this is very important message to my colleagues, neurologists. And I also want these Vitruvian plots adapted or used, whatever you say, in the clinical practice, because they are not really difficult to read or to understand. And I hope that the people start using them.
For me, one of the most important learning points is about evidence synthesis. So using these innovative approaches, we can use evidence synthesis to produce new knowledge, which is hidden in the data, but actually is there. So we can help inform the direction of future research using existing knowledge, but to advance the knowledge in the field. And the second point about evidence synthesis is this paper is a great example how we can use an evidence-based approach for a shared decision-making process in real world care. And this is of paramount importance, especially as Masoud said, because this can be done not only in Western countries, but this can be an approach and the medications can be used worldwide and globally.
Great. Well, thank you both for being on the Neurology podcast. I feel like I learned a lot. This was a fascinating paper and a really important contribution to our field and to clinical practice. So thank you both.
Thank you, Tisha.
Thank you.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.